Thank you very much. It's wonderful to be here. Yeah, it feels great. Yeah, so I'm actually mainly just an ID doctor, actually. But I'm going to speak today about drug-resistant TB. The reason why I'm going to speak about this is because Mark asked me to speak about some of our research activities. We're doing a lot of work in this area. So I thought this would be a kind of good topic to present. And so the talk is going to be this. Firstly, the scale of the problem, which most of you guys in this audience will know. But maybe I can give a different perspective. Some of the advances that have happened over the last decade in management of drug resistance. I'm just going to focus on the therapeutics and management of diagnostics and other issues. And then I'm going to speak about some of the research that we've been doing in this area, trying to address the emerging and big challenges, specifically around programmatic use implementation outcomes of management of drug resistance, TB. So to start off, the scale of the problem. In 1948, the treatment for tuberculosis was established, and through the first clinical trial ever done in medicine. It was a trial of streptomycin versus bed-rest. And in that trial, none of the patients actually got cured. There was an initial, what they called, this is the original paper, there was initial, what they called slight improvement or moderate improvement, or considerable improvement in streptomycin compared to the control. You can see that happened very early on. And as the months on treatment went on, the amount of improvements started getting less and less. Overall, there was more improvement in streptomycin, but it declined over time. And the reason why it declined over time was because streptomycin was given to monotherapy and resistance to the very early to streptomycin monotherapy. In this picture here, you can see just 100 patients in this trial that were summarized in terms of the emergence of streptomycin resistance. The first cross is the initial susceptible isolate. The second cross is the emergence of the resistant isolates. You can see it happened over a matter of days on streptomycin. But regardless, this treatment had to be given for a long time, and then after PAS and isoniazid were discovered, they were given in combination. But to effect cure in combination, which reduced the emergence of resistance, but to effect cure with this combination of drugs took about 12 months. Streptomycin alone did no cure, but in combination there was, but it took a long time. And the invention of rifampicin in the mid-1960s, and the introduction to clinical trial practice, which really revolutionary in terms of TB, because it allowed treatment shortly to 6 months when given in combination with other drugs. And with a cure rate in TB programs of about 80% in clinical trials, way exceeding 90%. So rifampicin was a transformational, revolutionary drug, and it has been used since those landmark trials of the combination short course therapy with rifampicin in the late 1970s. It's been used since then, right, as we all know. But it's been used in this particular way, and that is that it's been supported mainly by by diagnostics that don't test for resistance, so it means phenotype-based diagnostics, and even still widespread. And it also should be used without concomitant stability to the additional TB drugs that it supports treatment shortening in TB. And we really relied on this. And as a consequence of that practice and that situation, there was an emergence of resistance to rifampicin, and these are the kind of early reports in the 90s where there were outbreaks in hospitals of rifampicin-resistant TB in people with HIV. And you can see that again with rifampicin resistance, we revert back to like 1948, where the treatment outcomes are poor, and we require a long duration of treatments to cure people with TB with terrible drugs like these, and we've seen the pictures of those drugs. And 10 years ago, this was the state of TB treatment for rifampicin-resistant TB. So, kind of going back, 70, 80 years to the outcomes and just the patient's experience of terrible toxicity. And we know that the emergence of resistance to all anti-TB drugs happens quickly, and it's predictable, and it's just a timeline showing the emergence of resistance to different TB drugs in relation to their discovery and interaction. You can see that very soon after the introduction to these drugs, resistance emerged, including to the field components. And when there is resistance to rifampicin, and especially to second-line drugs that are used to treat rifampicin-resistant TB, the treatment outcomes are very bad. When these old drugs are used, you'll all know about this important epidemiological report from KwaZulu-Natal in 2006, where a cohort of patients who had HIV and were infected with TB strains that were resistant to rifampicin, but also to fluorouracil injectables, had very poor outcomes. All patients died. Almost all patients died over quite a short period of time. And this was thought to be attributable mainly to advanced HIV, but also because there was late presentation with the TB and treatable TB. And about 10 years later, this report came from Cape Town, where people with HIV also were included, and had XDR TB, over 100 patients. And the outcome in 5 years was dismal. 11% achieved favorable outcome, 73% of people died. And you can see in the bottom graph, there was no difference in the outcomes between those that were HIV positive if they were on ART versus HIV negative. So this wasn't HIV that was killing patients. It was actually untreatable XDR tuberculosis. And importantly, in the study, they showed, this is Tennessee study, they showed that around half the patients discharged from hospital had positive culture, so they were taking this TB straight into the community and it was getting transmitted. So this was an enormous problem. And so over the last decade, there have been some important advances to try and address this dire issue. And these are some of the goals in DRTB research that the field has tried to achieve. So these are the kind of key things that need to be done at that stage. So firstly, improving treatment outcome, just showing that the XDR is dismal. With just rifampicin-resistant TB, our XDR treatment success rate was about 50%. So even if it's pure susceptibility. Reducing toxicity with available drugs, getting rid of the injectable agents, which was the main cause of toxicity and intolerability, and then of course shortening the duration from 12 to 18 months back down to what is for rifampicin susceptibility. We know that the main advance to achieve actually all of these goals was the discovery of adapalene. These are data which I'm sure you're familiar with, and some notes very quickly from the South African TB program, where adapalene was introduced very early, and comparing outcomes between people that received adapalene in their treatment regimen versus those that don't. About 20,000 people were included in this analysis, including a large proportion of people that were HIV positive. This was in standard long regimens for TB, right? So this is anyone that got adapalene, and you could see that there was a significant mortality benefit among people with rifampicin-resistant TB and MDR, about 65% lower hazard of mortality compared to those that were injectables, and even among people with XDR TB, and the effect was greater, about 75% reduction in deaths, just when adapalene was in. And so it really is a very powerful drug, and many interventions in medicine can do this. And then very quickly, the program was introduced into the program. And also in parallel, there were these advances in short-term treatments with clofazimine and with the injectable to 9 to 12 months. And adapalene in the South African program was rapidly switched for the injectable to these shorter treatments regimens for drug-resistant TB. And you can see that compared to regimens, even the shorter regimens that had injectables, adapalene had a very important impact on outcomes. A higher proportion of patients with treatment success, 70 versus 47%. This was in a program using EDR web data, so programmatic data, not actually a cohort study that people enrolled into, which is using data. But when all these metrics, higher treatment success, lower loss to follow-up, higher disease-free survival, and lower mortality compared to people who received a shorter regimen just with injectable, you can see the mortality curves on the right that during treatments, the mortality on Budacamine was lower compared to those drugs injected, even though that disappeared after people had survived. So after treatment, that disappeared, or during treatment was better, and there was no difference in people with HIV. And then, again, in parallel with this important programmatic data, that actually just based on observational data from this TB program, the WHO guidelines changed and recommended, it started to recommend the use of that for vaccine-resistant TB. There were also trials that were going on in parallel with this. You'll be familiar with the next TB trial, which was a single-arm, uncontrolled trial that included 109 patients. They gave them a combination of 3 drugs that had been protomidate, similar to Dilaminid and linezolid, and had outstanding outcomes in the context of a clinical trial where patients were very closely monitored. This included people with very extensive resistance patterns, including XDR, and half of the patients had HIV, and the people with HIV did as well as people with HIV negative. And so really, 90% of people were cured after 6 months with these 3 drugs without injectable. Around a similar time, this other trial called TB Practical was done, where B-pill was combined with other drugs, oxytocin and clofazimine, and it actually showed superiority of the B-pill containing regimens compared to the longer B-pill regimens, again for 6 months. Again, a high proportion of people with HIV patients had pretty severe TB disease at enrollment, and they responded very well to this. It was superior, but the superiority was driven not actually by efficacy outcomes. In TB trials, they construct often these composite outcomes, which includes efficacy, so treatment failure and relapse, but also treatment discontinuation. The rates of failure and recurrence in this trial was actually 0 in both the experimental B-pill M containing regimens and the control. It was driven by discontinuation of treatments. There was much higher discontinuation. So these are well-tolerated regimens. They are highly effective in a clinical trial setting. And all of these studies over the last 10 years have influenced WHO guidelines to what they are today. I'm going to show you what the recommendations are in case you don't know. So we've gone from 18 to 24 months of treatments about 10 years ago to a 9-month treatments, including an injectable based on observational studies, and also later the Stream-1 trial, which was non-inferior for that regimen. And then based on South African operational data early on, maybe, but then a host of other trials, Stream-2, the NTB trials, we have 9-month injection-free regimen, and then based on Xenex TB Practical, we now have a 6-month full oral regimen for rifampicin-resistant TB. This is reflected in the WHO guidelines. There's 2 6-month regimens, B-pill M regimens, and then this B tuberculosis regimen that was done in South Africa by Francesca Conlon is now also recommended by WHO as a 6-month regimen that contains Dilaminid plus levofloxacin, linezolid. So plus linezolid with levofloxacin or vaseline resistance. And then there's also multiple 9-month regimens, oral regimens available for drug-resistant TB, including the one that's used in South Africa, which I'm going to speak a lot about just now, and then 3 oral 9-month regimens that were established in the NTB trial, which I won't speak around. So actually the situation right now is that we have achieved this goal. We've got treatment duration for rifampicin-resistant TB back down to what it is for rifampicin susceptible TB, drug-sensitive TB, 6 months oral treatment. And actually in these trials, it does as well, even better. So you could say, well, having drugs-resistant TB now might even prefer that to drug-susceptible TB. And actually the tolerability of these rifampicin regimens might be better. This is in trials, but we have this question: how does this actually perform in TB programs when things are like a little bit more messy, more difficult to implement, and for people to take, etc. And so we started doing a host of studies in the Eastern Cape, which I'm going to tell you about for the rest of my time that I have to talk. So we established about 5 years ago, 5 years ago, a site at this place called a TB hospital, which is in an area called Ransane, outside East London, South Africa. It's a TB referral hospital with 270 beds. And they've got the XDR, it's male, female, mainly adults, also some kids. They have some drug sensitive TB, mainly DRTB referral units for a very wide population of people in a high burden setting for drug resistant TB. Over time, I've established a research unit there where we have 5 permanent staff that work there in this building or structure, which has an office, a really nice office. You can see that here, a couple of clinic rooms, see a picture of them there. And then also we've installed a laboratory, which is really a fully functional BSL-2 level lab, which has centrifuges, high safety cabinets, nice freezers, PK studies, isolate PBMCs, and do molecular tests for TB and store a lot of samples. And over time, we've established this. The first study that we did at the site was a study called Shift TB that I'm going to tell you about, published a few months ago. And our main question for this study was, how does the 9-month oral vision that was at that stage implemented in South Africa and about to be recommended by the WHO, how does it perform in a TB program, a normal TB program, under routine care conditions? And so over about 18 months from January 2021, we enrolled 216 people, adults and adolescents with HIV and as well, including people with HIV and with newly diagnosed resistant TB within 30 days of entry to the study and who hadn't previously had rifampicin resistant TB. And we were going to start on this oral, shorter 9 to 12 month 7-drug regimen. And saw them quite intensively over the duration of their treatments. So like every 2 weeks for the first 2 months and then 6 8 treatment and then long-term follow-up. And we really wanted to know how they did. And in 2 ways, we kind of modified, we took a different approach to trying to understand outcomes, which can be a little bit complicated. So the primary objective was to measure the regimen performance. So what was the proportion of people that actually had a successful regimen, that finished the regimen and got cured? That's basically the WHO outcome for TB. So treatment success defined as completing the treatment within 12 months and also having sustained cultural conversion, so cure. And anyone that was lost to follow-up diet or changed their regimen, so the regimen wasn't used anymore, it was counted as an unsuccessful outcome. Then we had the secondary objective as well, which was we called TB-free survival. That was a measure of clinical effectiveness. So how well were the patients actually at different time points after starting treatments? And we measured this up to 18 months, and that just had 3 components. Was the patient alive? Were they free of TB? So do they not have any positive culture? And have they completed their treatments? Or were they still in care? So it was agnostic to whether they were on treatment or not, or one treatment or one, just how well they were doing. These were our 2 outcomes. So this was the population of the cohorts. 70% were HIV positive, about 60% were men. You can see there was quite a high coverage of antiretrovirals. Not at the beginning of treatment, about 60% were on ART at baseline, but probably started ART. But the median CD4 count was pretty low, 93. So advanced HIV disease occurring together with drug-resistant TB. About half of people was a new case. That means there's transmitted rifampicin-resistant TB. It's the first time they're getting TB, which is known, that drives the epidemic with transmission. And maybe of interest, I don't know how accurate this is. We measured the HbA1c in people, but we know that we can't go up and down with TB disease, but about 11% had unrecognized diabetes. The pie chart shows the profile of the TB strains, and about 85%, 86% were rifampicin resistant TB, 14% had extended resistance, 9% also had pre-XDR TB, so resistant TB. Interesting, there was some discordance between gene export positive and culture positive. There was some that were just gene export positive, there were negative cultures, which we are trying to look into. And so here are the results. You can see that this dacline containing regimen was extremely potent from a microbiological point of view. This is time to culture conversions, proportion of people they culture converted over time. And you can see here this vertical line, median time to culture conversion is about 30 days. So half of people were culture negative after taking this for 1 month, which is astonishing. It's like as good as rifampicin obtaining a regimen for drug sensitivity. And almost all patients had culture converted by 90 days. And I'm not showing that here, but we stratified this by HIV and by hormone resistance and found no difference. So this regimen is highly potent. It's very good against TB, even in a program. But what were the clinical outcomes? The regimen performance was actually terrible. The unsuccessful rate, so the regimen success was less than 40%, 62% of unsuccessful treatments by that WHO definitions of the regimen. And the reason why is because you could see almost 20% were lost to follow-up, and 35% were classified as having failed regimen. And the main driver of that is changing drugs. So not actually bacterial failures, but people switching to the longer regimen, so that they've failed shorter regimen. And we did some adjustments for reasons why people have switched from the beginning. For instance, knowing if they're hormone resistant or have extensive disease on the chest X-ray, we still found that the regimen success rate was quite good, at about 50%. In terms of this other metric of clinical outcome, 18 months TB-free survival was also quite low. So even on clinical outcomes, this regimen didn't perform so well. 42% were alive, TB-free, and had comprehensive treatments by 18 months. 18% of people had died. And really the lack of TB-free survival was driven by high mortality and loss to follow-up because of the assessed in 16%, because we just don't know what happens this time. There were also, I just want to show you more about loss to follow-up. This survival curve here shows the time to loss to follow-up over the 18-month follow-up period, study period. The cumulative loss to follow-up was about 30%. The median time to treatment interruption was about 4 months. And this is not, if you think about it, surprising, because people are culture converting at 3 months. So it's even better, and then disengaging from care and getting lost to follow-up. A lot of people though found, and 60% of them returned to care. At the time that they returned to care, about a quarter of people had positive cultures. And surprisingly, half of those people that had positive cultures were then resistant to their. Speak about that a little bit later. Other things that may have influenced very poor outcomes for this regimen is that there was quite a lot of, as expected, social deprivation. You see about a quarter of people in their primary school level education. Half of people earned less than $275, and about 35% were social grants, and half of people were classified as having alcohol misuse disorder. And so really a lot of factors feeding into this. But we became very interested in to look more closely at these drivers of loss to follow, also drivers of these poor treatment outcomes. So within the study, we did an adherence analysis, and we gave as many people as we could that were involved into the study, 260 were involved. We gave them these boxes called wise pill devices. Here's a picture of it. It looks like a cardboard box. It's the size of like a small medium pizza. And inside is this electronic device that measures when the box gets opened. And so the patients put their drugs in it, and when the box gets open, that's a proxy for taking their treatment drugs. Obviously, it's not actually taking their drug, but it's a proxy for it. And so we can use this to monitor adherence over time in people. And we also, when the patients were in hospital, we didn't do it in hospital to direct to therapy, so they recorded when the patients swallowed their tablets for the patients that were hospitalized. So we use these two measures of adherence. And we measured it until 9 months, or until they reached some sort of outcome, although transferred out. Adherence was defined as the proportion of drug intake days, so a box opening, versus over accessible days, so that's when the actual box is working. I'm not going to speak about this because technical issues to this thing. And then we wanted to understand how different people behaved and different groups behaved over time. And did this analysis approach called latent class analysis, and what's called group-based trajectory model. I'll show you just now. It's a way to use the data to separate people out into groups based on the pattern of adherence data over time. So here are the data. Here's the data. 209 patients provided a lot of information. They're almost 38,000 accessible adherence days. You can see all of those adherence days are plotted on this kind of heat map over here. So each row is a patient, and each dot represents something different. The green means they've had an intake, and the yellow means that they haven't had an intake, so the box wasn't open, and the grey is when there's missing data, no data. And you can see that it's very patchy, the interrupted intake, but it happens often, right? And we measured that about 85% of people overall had a treatment interruption. Very common that people just skip taking their treatments. There were a median of 14 interruptions per patient over the duration of their treatments. Very erratic, and you can see the pattern here. And most interruptions were very short. You can see that in this histogram here. These are the number of interruptions of at least 1 day. And you can see that many people had interruptions of at least 1 day. And so short, frequent interruptions characterize this adherence pattern in this region of rows T. And these are the summary measures of the adherence over time. This picture over here shows, I'll just unpack it for you. The purple is when the digital pill box was used. So the x-axis is time on treatment. Y-axis is just a proportion of patients. Purple is when the digital pill box was used. The blue is when the DOT was used. The gray on the top is when there's no data. And those lines are just the proportion of people with adherence over time. You can see that it goes down over time. Median adherence overall is 72% with the electronic adherence monitoring device. And when we did this latent class analysis, we could separate out 4 different groups of 4 different adherence patterns. In the first month, you can see it on the left as well, right? You can see it. The adherence was very good, between 88 and 100%, but then separated out into these 4 groups. Green, you can see, was very good and stayed very good over 9 months. The yellow wasn't that good, was less good, but it's kind of stayed at that constant level. It's dropping slightly over. So then the orange and the red were bad. And in those 2 groups, by 3 months in the red, there was a 50% reduction in adherence in 22% of patients, and 17% reduction by 6 months. Sorry, the 50% reduction by 6 months and 17% of patients in orange. And so we can clearly pull out different adherence patterns in this data. We wanted to understand what caused people to belong to each of these different groups to try and maybe influence their treatment adherence. And so did some analysis to try and understand this. And there was an 80% probability more of belonging to group A, that this really nice green group over here, if people were older, if they had a period of hospitalization, any period of hospitalization during their care, or if they received an individualized regimen. So weren't just on shorter regimen, but switched to a longer individualized regimen. Speak about we try and understand why adherence would be better than later. Group D membership, so this group, this red one at the bottom, the worst one was associated with this risk of loss to follow, not surprising. And I haven't shown this here, but better adherence was also associated, unsurprisingly, gave some internal validation with improved time to culture conversion. Other factors that could possibly explain this decline in adherence over time, I've already spoken about this. There's potent reduction activity in the shorter regimen. People might interrupt after they feel better. We know that 70%, almost 80% were culture negative at the time when they were lost to follow up. So they were free of TB and they disappeared, which again, might not be surprising when patients are doing it. A lot of social vulnerability, but we did try and analyze relationships between that and adherence patterns could find. And then we know that the NESLIT toxicity is still an issue. In a previous cohort, 21% of people discontinued NESLIT. Discontinued NESLIT because of perceived or actual toxicity. So all these factors together might influence how people take the drugs. I'm going to end off by speaking about bedaquiline resistance. I already kind of touched on this, but it's as this group probably knows, an emerging and important problem, especially in sub-Saharan Africa. Graham and I have been involved in another study, which also included the site, where multiple sites around South Africa where we took the cultures of people who had returned to care after interrupting bedaquiline-based treatments. And in this cohort of patients, 35% were culture positive when they came back to care, and more than half of them had bedaquiline resistance. That's culture isolate when they came back to care after interrupting bedaquiline. So this is, we can see there's a lot of loss to follow up. There's a lot of positive cultures when people come back. There's a lot of bedaquiline resistance that emerges after that happens. Prevalence is very high around South Africa, and it's very heterogeneous. In one province, about 10%, alternatively it's the Western Cape. And in people, and that's just in unselected people with famous TB. And that's higher if there's been previous exposure. In this report, 60% had no documented previous exposure to bedaquiline. So that strongly suggests that it's getting transmitted bedaquiline resistance TB. This is published in Mozambique, where we increased the prevalence from 3% 10 years ago to 14% in 2021. So it's increasing in sub-Saharan Africa. And we know there's cross-resistance with clofazimine of more than 90%. Clofazimine has been used a lot in South Africa. And this is driving this is the effect that's driving it. We're pretty sure that there worse TB outcomes with bedaquiline-resistant TB. There's uncertainty. There actually isn't a lot known about how these patients do. And we just have no idea how to manage the patients. We don't know how people are managing patients in TB programs. There's no like normative treatment guidance for this. So we saw this, and at our research sites in East London, we noticed after speaking to clinicians there that they were seeing patients with bedaquiline-resistant TB. And one of the medical officers there approached Graham and I and said, interested in doing some research. And we said, well, there's, you guys are seeing these patients. Why don't you just write a case series and describe them? And this guy called Leon did that. And he got a Lancet ID first author paper by doing this very simple study where he collected over a period of time all of the cases of bedaquiline-resistant TB that they had at the hospital. And in the end, they had 82 people that included in this retrospective cohort. People older than 13, evidence of pulmonary TB, and confirmed bedaquiline-resistant TB and phenotypic drug-resistant TB over this time period until June 2023. But what we also did is that over this exact time period, that's when we were enrolling the cohort that I just spoke to you about, so the fampicillin-resistant TB. And we thought there would be a much stronger paper, would kind of lend its validity if we had a matched cohort of bedaquiline susceptible patients to compare the outcomes in this group. So we matched patients to this bedaquiline-resistant cohorts from our observational cohorts of fampicillin-resistant TB and confirmed that they had rapid bedaquiline susceptible TB. And it was over a very similar time period. So all patients starting treatment for fampicillin-resistant TB confirmed susceptibility. We matched them for age, HIV, and whether they were culture positive or negative, and 82 people included in that cohort. This is the profile of people with bedaquiline-resistant TB that's been quickly found. Not unexpected, young, about half were male, 50% were smear positive, and 70% were HIV positive, so really unique cohorts. Bedaquiline-resistant TB patients, they could probably only find that. And among the people with HIV, the median CD4 count was 967. Half of people had previous rifampicin-resistant TB, and only 80%, almost 80% of previous treatment with bedaquiline or clofazimine, which means 20% were transmitted. The first time that they had TB was bedaquiline-resistant TB, which is quite scary. Here's the summary of the kind of resistance profile of the strains of the patients that were included in this cohort. So 88% were non-resistant, which is higher than the kind of national average. National average is about 40–50% with bedaquiline-resistant TB. That's because our study was enriched. It was part of our search criteria. We found people with resistant TB to identify these patients. A high proportion. And only 50% were resistant to NK cell which is now 90% also resistant to clofazimine. And at the time that the bedaquiline-resistant sputum was taken, called index sputum, 2% were resistant to linezolid. But later on in treatment, at some point after collection of that index sputum, that number had gone up to 21%. There was emergence of linezolid resistance in this population of people with bedaquiline resistance, which is also incredibly scary because it's hard to get resistance to these. And of the people that had a bedaquiline susceptibility result before entering the study, 95% had sensitive results. So people were going from bedaquiline susceptible to resistant on treatment, and also getting transmitted bedaquiline resistant. So here's a description of the cohorts. It's a busy picture, but this is the treatment journey of each patient that is included. It's separated by their outcome. We applied the same outcome that I described earlier, the TB-free survival outcomes to this cohort as well. So alive, no evidence of TB, and in care or completed treatment by 18 months. That vertical line is when the dashed vertical line in the middle of the picture is when the bedaquiline resistant sputum was taken. And those colored lines are the time on treatment. So that means they're on treatment where there's a colored line. Blue is on bedaquiline treatment. So the first thing you can see is that many people continued bedaquiline after that initial sputum that had bedaquiline resistance in it was taken. The round black circles, you can see them, are when the report of the bedaquiline resistance result was put out on the computer on the system, and that result became available. The median time to getting a result from sputum being taken is 4.5 months. So really a long delay in recognizing the diagnosis of resistant TB. The yellow diamonds are when there was sustained sputum culture conversion. You can see a lot less sustained sputum culture conversion at the bottom because they didn't have a good outcome. But many patients, surprisingly, we can speak about this just now, converted their sputum before the results of the bedaquiline resistance came. And they were, you can see there was during the blue treatment line, they were on bedaquiline. So people with bedaquiline resistant TB were culture converting on bedaquiline based therapy even before their result was known. People were treated for very long, the median treatment duration after that initial sputum was taken. You can see not the overall treatment duration, but was way before bedaquiline resistant sputum was sent. But the median duration after that percent was almost 18 months, and 25% had longer than 20 months. And bedaquiline was used at some point for almost 90% of people with bedaquiline resistant TB. We tried to map what treatment they got. It was quite difficult to understand how to visualize this, but we did this through two different ways. This is just one of the ways, through a heat map. So this is on the x-axis, the months since treatment initiation for bedaquiline resistant TB. And the different colors are the proportion of people on each drug. And it's very small, but the drugs are listed on the y-axis in different ways. And you can see from the heat map that the most frequently prescribed drugs were bedaquiline itself, right? That's the second one in the pictures, which kind of starts, I think, when clinicians started recognizing, started getting the results of bedaquiline resistant TB, they switched them off. So it kind of gets lighter over time. But almost all patients got it. Then there's linezolid, and that's the top one. So that was a very widely used drug for this condition. Taururzidone, which was also, it's basically a purple solid line, so it was used widely as well. And also, despite bedaquiline resistant clofazimine, what was widely used as well, almost in everyone, almost for the entire duration of treatment. Despite 50% being susceptible to amikacin, no patients in this cohort got amikacin treatments. And we don't know exactly why this is, but it must be because we think it's because people are still very scared and reluctant to use these injectable drugs. They're difficult and unpleasant to use and everything. Even though they're highly effective, people are avoiding them. We captured how many people have meropenem, which is an option, treatment option for people with TB, together with clavulanic acid. And it was only included in the regimen in 40% of people. And started, again, this reflects the delay in diagnosis, about 4 months, at the end of 4 months after the sputum was taken. And it was used for about 6 months in half of the patients. And so it wasn't that widely used despite patients having this condition that is just almost untreatable. This is a last line resort treatment. It still wasn't that widely used. Again, slightly surprising, maybe because of the difficulty of administration, that people hospitalized, they need grinders and other issues. But maybe also because clinicians were seeing that bedaquiline was potentially effective in this population. We'll speak about that in a second. These are the treatment outcomes. And this is, again, a microbiological outcome. It's time to culture conversion. This is the entire cohort. They matched rifampicin susceptible cohort and the bedaquiline resistant cohort and stratified by those two groups. And you can see that the blue time to culture conversion in those that were bedaquiline susceptible was rapid, just like we saw with the cohort study, and much, much slower if people had bedaquiline resistant TB. So whatever treatment regimens they're using, not very effective, right? At least from a microbiological point, much less effective. The time to sputum culture conversion was 137 days earlier than the bedaquiline susceptible cohort. Median 175 in the resistant, 32 days in the susceptible. So these drugs don't work very well against TB when there's bedaquiline resistance. These are the treatment outcomes. Again, we use these two same outcome definitions that I described here. It's WHO outcome. 33% had favorable treatment outcome, 43% had failed treatment. And unlike the previous cohort that there was dry failure, was actually treatment failure, microbiological treatment failure, lack of culture conversion by month 6, and cultural reversion in the follow-up time. So people are actually genuinely failing treatment, but these drugs are not very effective. This is the TB-free survival outcome at 18 months. At 18 months, 80% of survivors still on treatment. So this condition requires prolonged treatment because people just don't culture convert. Around 10%, only 10% in the background resistant were live TB-free and had completed treatments at 18 months. Just a terrible outcome. And surprisingly, the last two follow-up is lower compared to bedaquiline susceptible cohorts. And thought about this. Maybe it's because people are being looked after kind of more carefully if they have bedaquiline resistant TB, and they brought back, maybe they've got more hospitalization. But there's less loss to follow-up. So they're taking their treatment, they just can't get off because they fail. This is the mortality, and there was no statistical difference in mortality between the two groups, susceptible or resistant. The mortality was still high at 18 months, 22%. So almost a quarter of people die with this condition, which is really, really unacceptable. And a little signal from the data, we looked for associations with mortality. We found that anyone that received, people receiving bedaquiline, there was a hint of reduced mortality. So bedaquiline exposure seemed to be protective in this analysis. It's not perfect, but it might be a hint that bedaquiline may still be effective in these patients with bedaquiline resistant TB. Interestingly, meropenem use was not associated with survival. And then finally, before I wrap up, I want to just tell you about a trial that we are at some point going to start. This is funded by the European Union. It's a collaboration with the LMU, the University of Munich. And it's a trial for people with bedaquiline resistant TB. It's the first of its kind, and obviously we think it's very important to give them scale and severity of this problem. So the trial is designed that we will identify people with bedaquiline resistant TB at about 6 or 7 different sites in 3 different countries with targeted next generation sequencing, so molecular tests, and then randomize them to 3 different interventions. Actually, initially, it's just only 2 different interventions. We'll add a third on later. But the interventions are a control group with the current national standard of care, whatever that is. And then the intervention of an experimental group, which is going to contain 4 or 5 drugs. Drugs that it's going to contain are all oral, and 3 of them are novel drugs. One is ganfebrol, which is a protein synthesis, a novel protein synthesis. So it's a cell RNA, tRNA base inhibitor. And the T stands is for a drug called BTC, which is a DPRA1 inhibitor. It's with cell biosynthesis. And then DPC is dipepazolone, which is amoxicillin, also works against protein synthesis similar to the. And then the fourth drug will be pretominated in all of the patients. And depending on equivalent susceptibility, they will get moxifloxacin or not. This experimental treatment will be given for 9 to 12 months. We're still deciding how to extend that. There'll be a follow-up to 24 months. And the outcome is unfavorable efficacy outcome. Not that composite outcome of treatment discontinuation, that's going to be a pure efficacy outcome. With treatment discontinuation is the same. And we're hoping to start this trial towards the end of this year. It's a complicated thing because these drugs are, they have industry partners, and you can imagine contractually it's difficult to go through. The third regimen is going to, or the second experimental regimen is going to contain an additional drug instead of protonidate, which is a novel diaryl poly, the same class as bedaquiline. It's probably going to be the 587 molecule from TB Alliance. And in vitro, this drug seems to be effective in strains with bedaquiline resistance mutations. It has better PK characteristics. So that's a trial that we will start and excited about. So just to do some concluding remarks, there's been major progress in DRTB treatments. New evidence-based regimens are available, are shorter and effective, they're oral, safer, better tolerated, but there are ongoing challenges. Performance doesn't look that good in programmatic operational settings. We've shown that work in Eastern Cape with still a very high mortality and very problematic rates of loss to follow-up. We don't fully understand it. But bedaquiline resistance is a major threat. We showed that there's delayed detection, the outcomes are poor. There's prolonged culture positivity, which encourages transmission and with few treatment options. And so priorities in this area, in this field, are, we think, better near patient diagnostics, that we can recognize resistance early and start having effective and potent treatments. TNGS has been rolled out across South Africa in the program, and we'll see what impact that has. It's going to be interesting. And then we need to understand newer drugs, and we need to have good quality evidence for their use and effectiveness in these forms of TB. So I just want to thank the people that were behind these studies. Ati did led the Shift TB cohort study. Johanna was a postdoc with us. We did the adherence work. Zaka worked with Liverpool Clear on the resistance stuff. Graham, thank you for being a very close